Bismillahirrahmanirrahim. Assalamu alaikum. I welcome all my dear students to today's lecture of cardiovascular physiology, and one of the very important aspect is actually the heart sounds. Now today we are going to learn that what are different heart sounds and what is the cause of their um, presence and what is their significance and what are the different segments of the cardiac cycle during the course in which we are going to hear the heart sounds, what are the different areas of the chest for auscultation regarding the heart sounds, what is phonocardiogram, what is the pathophysiology importance of these heart sounds. So this is actually the topic which is concerned with that of the phonocardiogram portion of the cardiac cycle. You can be asked about this segment alone. Now, what are the different heart sounds which we heard? And you know precisely that there is presence of first heart sound, the second heart sound, the third heart sound, and the fourth heart sound maybe. So you can see that there is in the diagram presence of the phonocardiogram recording, which is actually the graphic representation of these different sounds which are heard in different phases of the cardiac cycle. And in the lower diagram you are seeing that different coinciding areas of ECG with that of the heart sound. That at course of like P wave you hear what sound, at S1 you are going to hear over there at the QRS interval, QRS complex, and then S2 and S3. So S1 is actually the first heart sound which you are going to hear at the onset of ventricular contraction. Then we have S2, which is the closure of semilunar valves. Then there is presence of S3, the third heart sound, which we are going to hear during the course of ventricular gallop. Then there is presence of atrial gallop, which is heard in the form of fourth heart sound. The other can be the opening snap, the ejection sounds. There may be presence of murmurs. Now let's see what is the different areas of coinciding areas of the heart sounds with that of the different segments of the cardiac cycle. You can see the first heart sound, then there is second heart sound, the third heart sound, the fourth heart sound, and they are all you can see at the bottom in the form of a phonocardiogram. Now, when we talk about the heart sounds, the question arises in our minds that what is the actual origin of the heart sounds? Because the slapping of the valve's leaflets is not enough to generate a heart sound. So, up till now, there are different theories regarding it. There is presence of the valvular theory, there is presence of the cardiohemic theory. Now, the valvular theory says that the vibration of the heart valves during the course of their closure, there is production of the heart sound. Most of the people, they actually have this mutual consensus about that the closure of the heart valves is actually responsible for this presence of heart sound. Then the cardiohemic theory, the vibrations of the entire cardiohemic theory, the vibrations of the entire cardiohemic system, the blood cavities, the valves, the blood, they are responsible for this origin of the heart sounds. But the most of the people, they have mutual consensus upon the valvular closure theory. Now let's talk about the origin of the first heart sound and the second heart sound. This is very important and frequently asked. Now let's talk about the origin of first heart sound first, and that is that during the course of systole contraction, the atrioventricular valves they are closed and blood tries to flow back to atrium, and the back bulging of the AV valve occurs. But there is presence of the taut chordae tendineae, and they stop the back bulging and causes the blood to flow forward. And this will cause vibration of the valves, the blood and walls of the ventricles, which is presented as the first heart sound. So the closure of AV valve, remember, is responsible for the creation or origin of the first heart sound. Then we have the second heart sound. Now, second heart sound is actually the heart sound which is occurring during the course of diastole. Now, what happens is that during the diastole, the blood in the blood vessels they triad to flow back to ventricles, causing the semilunar valves to bulge. But the elastic recoil of the arteries causes the blood to bounce forward, which will vibrate the blood, the valves, and the ventricle, and this is presented as the second heart sound. Now let's talk about the frequency. The first heart sound is having the frequency of 10 to 140 hertz, and the second heart sound has the um, frequency from 10 to 400 hertz. Now the time between the S1 and S2 sounds is actually the ventricles contracting, the blood flowing from heart to lungs and body, the blood flowing across the pulmonic and aortic valves. Then diastole, the time between the S2 and S1 is the blood is flowing from atria to ventricles, the blood is flowing across the bicuspid and tricuspid valves, the atrial contraction also occurs now. Now S1, what is it? The lobe in the lobe dope. This sound is primarily because of the closure of bicuspid and tricuspid valve. Anatomically, they are located between the atria and the ventricles, and they close because the ventricles contract. The pulmonic and aortic valves are opening and the blood is being forced into the arteries. This is actually the time when there is origin of the first heart sound. So first heart sound is actually because of the closure of the atrioventricular valves, which are the bicuspid and tricuspid valves. And at the same time when they are closing, there is opening of the pulmonic and aortic valves, remember. Now first heart sound is long, it is dull, it is soft and low pitched, frequency of like 30 to 50 cycles per second, duration of about 0.14 seconds, and described as lobe, and is due to the vibration in the closure of atrioventricular valves, and occurrence is at the beginning of ventricular systole. It is not the sound of closure of valves, but is produced by the vibrations due to closure of atrioventricular valves. Now, what is the significance? Now, its significance of the first heart sound is that it indicates the ventricular contraction. It indicates the ventricular systole. Its duration and loudness indicates condition of myocardium. It indicates the compliance of atrioventricular valves. Physiological splitting of first heart sound occurs due to fact that tricuspid valve closes slightly earlier than the mitral valve. Interval between the first and second heart sounds is the duration of ventricular contraction. It is the duration of ventricular systole. Now that you hear the sounds, what does it mean? First heart sound, louder than usual, mitral stenosis, variable atrial fibrillation, complete heart block, diminished mitral or aortic regurgitation. This is the first heart sound. If it is louder, then there is mitral stenosis. If it is variable, it is not static. It is atrial fibrillation. There is heart block. If it is decreased, there is aortic regurgitation. There is mitral regurgitation. So there are so many aspects which we can see. Now, when we are knowing about the first heart sound, we should know about dub as well. Now, what is it? S2. The sounds are being produced because of the closure of the pulmonic and aortic valves, as the pressure from the arteries is greater than the pressure in the ventricles. And it is indicating us about the compliance of the semilunar valves. It is telling us that there is end of systole. Now, the second heart sound, it is short, it is not long like first one, it is sharp, it is not dull, it is high pitched, the frequency is 50 to 200 cycles per second, the duration is 0.11 second, it is described as dub. It is consisting of two components. Now, what are they? There is presence of aortic component, there is presence of pulmonary component. Aortic component. Now, it is best heard in aortic auscultation areas, and its intensity is increased in systemic hypertension. Then there is pulmonary component, and it is best heard in the pulmonary auscultation areas. Its intensity is increased in pulmonary hypertension. Second heart sounds. What does it mean? Wide split sounds are fixed, not moving with respiration may indicate the atrial septal defect. Then there is pulmonic stenosis. So it is very important, if there is some sort of pathology going on, that we are going to detect that there is something went wrong with that of the heart. Now, when we are talking about the most important sounds, which are the first and the second heart sounds, there is presence of the other heart sounds as well. The other one is the third heart sound. It is heard in the mid diastole due to the blood which fills the ventricles. It indicates the beginning of ventricular filling. Then there is fourth heart sound, also known as atrial heart sound. It occurs when the atrium contracts and pumps the blood to the ventricles. This sound is almost never heard by the stethoscope. Now, significance is that it indicates the end of ventricular filling, and it occurs just before the first heart sound. Now, what is the pathophysiological importance of these heart sounds? They are like the third heart sound is markedly diminished if there is left ventricular functional defect, almost always absent with myocardial ischemia, or early after an acute myocardial infarction. In the fourth heart sound, it is modestly diminished left ventricular function. Auscultation. The listening of the heart sounds with the help of a stethoscope is called the auscultation. The first and second heart sounds, they are commonly auscultated. The third heart sound is sometimes auscultated, whereas the fourth heart sound is never or rarely auscultated. You should be knowing about it, that if you're being asked about that, please can you do the auscultation for like fourth heart sound for me? You're going to say no. I'll try, but it is never or rarely auscultated. Then, when we are going to talk about this auscultation, we should be knowing about the areas on the chest wall where to auscultate. We should be knowing about the four important areas, which are the aortic area, pulmonary area, mitral area, tricuspid area. The aortic area, it is in the right second intercostal space along the sternal border. Then we have the pulmonary area. It is in the left second intercostal space along the sternal border. Then there is mitral area. It is in the left fifth intercostal space, 1 centimeter medial to mid clavicular line. Then tricuspid area. It is in the fourth intercostal space at the left sternal border. See the different areas you can see: aortic area, pulmonic area, tricuspid area, and mitral area. How to use the stethoscope? The diaphragm of your stethoscope is most useful for picking up the high-pitched sounds. That is, the S1, S2 aortic or mitral regurgitation murmurs or friction rubs. The bell is most useful for picking up low-pitched sounds, S3, S4 or mitral stenosis. So diaphragm is for high-pitched like S1, S2 mostly, and the bell, which is for the low-pitched sounds like S3 or S4. Now there are other different kinds of sounds which you can hear with your ear as well. They are like murmurs, which usually indicate that there is presence of some disturbance, some turbulence, and they range from 1 to 5 in loudness. Does it occur during diastole or systole? Does it crescendo, getting progressively louder? Does it decrescendo, getting progressively quieter? And where do you hear it best, whether in the neck or chest or axilla? These are the different points which you are supposed to keep the things in your mind while you're going to listen for the murmurs. The other sounds, they are the gallops, the rubs. Gallops are either S3 or S4 sounds. Rubs, the pericardial or pleural friction rubs, are usually indicated either pericarditis or possible pleurisy, and must be careful to listen to both the heart and lung sounds. And the rub sounds like sandpapery. Then there is presence of clicks, diastolic knocks, continuous murmurs. The clicks only occur in systole and represent the loud valve closing. Diastolic knock occurs because of an abrupt arrest of ventricular filling by a non-compliant and constricting pericardium. Continuous murmurs indicate a constant shunt flow throughout systole and diastole. That is the coarctation or patent ductus arteriosus. Volumes. Cardiac output. Cardiac output, then we have the stroke volume, ejection fraction, the venous return, the pressures, left ventricular and diastolic pressure, the preload, aortic pressure, afterload, time intervals, pre-ejection period, the left ventricular ejection time. Cardiac diagnosis. There is presence of non-invasive diagnostic modalities, and there is presence of invasive uh, diagnostic modalities. So whenever a patient comes to you, we are always going from easy to complicated diagnostic tools to determine the um, pathology going on. So the first non-invasive should be the electrocardiography. That is the electrical representation of the cardiac activity on the paper. And you all know that what is that? That is the ECG. Then what is the other thing? That echocardiography that is being done. Then impedance cardiography, then auscultation, palpitation. They are the easiest things which a clinician can do. First, you go for auscultation, palpitation, then we are going to go for the ECG, then echocardiogram, and then impedance cardiography. And God forbid, if still the diagnosis is not confirmed, the clinician is going to go for the angiography. And what is being done in that there is a dye filled test, invasive test, which is going to give us the idea that what is the different functioning of the heart going on. And in addition to that, the other thing is the right heart catheterization, known as the Swan-Ganz catheterization. That is the one of the invasive cardiac diagnostic modalities which are being used to find out the different pathologies going on in the heart. So this is all about the heart sounds, which are actually being shown in the form of phonocardiogram in the cardiac cycle base. So you're all supposed to know what is the importance of S1, S2, what are S3, S4, what are the abnormal heart sounds, what are the different pathologies of the heart which we can relate with it. So this is all about today's lecture. Give a good reading to it from your book Guidance as well, and try to uh, get a good grip on this topic. So stay blessed and all the best. Allah Hafiz.